हाँ अभी दिया नहीं है, अभी आपको बूस्ट बना देते हैं तब आप कर सकते हैं, ठीक है।
लिखने वाले को टाइम भेजो।
बट ऑडियो हम इसी से रखें।
Good afternoon, everybody. A very, very good afternoon to all of you. I hope you're doing fine. And we are back with you again. At this time, we are trying to experiment with YouTube live streaming as well as the Zoom. So Zoom is a convenient platform for a lot of people. Therefore, we will be doing it. I've already made you a host, Dr. Neha, and you can actually, I can see your screen also. So it's that way it's quick. We'll wait for another maybe 5 minutes as more people join in. And please, everyone else, mute yourself. Mute yourself, please, everyone. Except Neha, everybody should be muted. So, good afternoon, everyone, again. Let's get on with it. I think, Dr. Neha, your presentation is visible. So, you can start making your presentation, please.
Right. Good afternoon. I'll be presenting a case on parotid swelling today. 17 years gentleman resident of Mathura, farmer by occupation, presented with chief complaints of swelling in front and below the right ear since 2 years and pain in the swelling since 2 months. History of presenting illness. Patient was apparently well till 2 years back when he noticed a swelling in front and below the right ear lobule. The swelling was insidious in onset and was about 3 centimeter in size. Initially, it was increasing slowly in size, but over a period of last 2 months, there is a rapid increase in size to attain the present size of 8 into 7 centimeter. Initially, it was painless in nature, but now patient complains of dull aching pain over the swelling from last 2 months. There is no history of pain or variation in size while chewing food. There is no history of purulent discharge. There is no history of asymmetry of face, no history of difficulty in closing of the eyes, no history of difficulty in chewing food, no history of drooling of saliva from the angle of mouth. There is no history of any other swelling in the neck and no history of any comorbid illness. And there is no history of constitutional symptoms such as fever, malaise, and generalized weakness. Past history, there is no history of exposure to radiation to head and neck in the past. There is no history of previous surgeries in the same region in the past and no history of mumps in childhood. Coming to the personal history, he is non-alcoholic and non-smoker. Sleep and appetite are normal. Bowel and bladder habits are normal. He consumes a vegetarian diet. And in family history, there is no history of head and neck malignancy in the first degree relatives. To summarize, 70 years gentleman with no known comorbidities presented with history of progressive swelling in front of and below the right ear for past 2 years with pain and rapid increase in size for past 2 months with no history suggestive of facial nerve palsy. Shall I proceed,
Yeah,
sir?
so couple of points in the history, most of the aspects are covered. So you need to start from the first slide to
Right,
go back to the points. Yes,
sir.
this one. This is okay. Now, see, swelling in front and below the right ear since 2 years is fine. Pain in the swelling since 2 months is perfectly okay. Next.
Sir.
Apparently, well, till 2 years ago, when he noticed the swelling, that's fine. Insidious is fine. It's been growing slowly ever since. So rapid increases for the last 2 months.
Yes, sir.
And there is pain for the last 2 months. So actually, there's a change in the behavior of the swelling for the last 2 months.
2 months.
Next one. Now, when it comes to no history of this, no history of that, no history of this, no history of that, it's a good thing to put it in one breath.
Right.
There is no history of pain or variation in size of chewing the food or purulent discharge, asymmetry of face, difficulty closing of the eyes, or chewing food or drooling of saliva from angle of mouth or any other swelling in the neck. There is no history of any comorbid illness and constitutional symptoms. So don't make it into a laundry list 1, 2, 3, 4, 5. That I often insist on, although it's not a very major point, but it looks very repetitive. You would appreciate. Next. Yes, no history of exposure to radiation to head and neck areas in the past. It has already been discussed. What kind of radiation you are referring to?
Sir, for radiation regarding treatment for lymphoma or any other illness in the past during childhood.
Yeah, actually, you see, basically, what kind of radiation? It's the high dose or the low dose that predisposes to cancer?
Low dose radiation, sir.
So that is very rarely given these days, right? So because if it was for lymphoma, why would they give a low dose radiation? So usually it is something which is obsolete now, but relevant still in view of, some people living close to nuclear reactors or getting exposed to places like Chernobyl or close to Hiroshima, Nagasaki, etc. Right? Otherwise, you won't get low dose radiation. Nowadays, there is also talk about these towers which are used for the mobile phones, etc. Although it's not established, but they are talking about it. So low dose radiations are usually not therapeutic.
Sir.
Because there is no therapy. Or the other situations could be which is not done now for acne or for adenoids. In the past, they were given radiation. Because today, radiation is mostly given for malignant conditions. I'm using mostly because maybe there are 1 or 2 conditions where it is given for even benign conditions. I'll ask you later on about that.
Right.
Now, no history of previous surgeries in the same region is relevant. What is in your mind?
Sir, any surgery related to the lymph node, like lymph node biopsy, could be taken in the past, or any surgery for the
Or any surgery that would be related to this problem.
yes, sir.
Like, you see, one is very obvious. Yeah, don't get confused. There was a surgery done for parotid swelling earlier in his record. That's one. Or there was a lymph node removed earlier, which you have already mentioned.
Sorry.
Beyond that, there is nothing that would, the only reason why you want to find out for a surgery in that region is either that some benign lesion was taken out earlier, now there is a malignant change, or there was the same surgery done again, that is recurrence. Okay?
Recurrence. Yes.
Now, what is the significance of mumps in childhood that you mentioned here?
Sir, in mumps shows the low immunity status of the person, and patient may get recurrent attacks of mumps, and mumps can even be seen in adults with low immunity.
No, it's not immunity alone that mumps would be relevant. The mumps would be relevant even for parotid swelling. Mumps produces bilateral parotid swelling, so that history would be very typical. And what else you will find in that history when you get the history of swelling of the parotid in mumps?
So there will be associated pain and constitutional symptoms.
Well, there will be fever and viral features, anything specific which is going to be relevant here. So there is mumps parotitis, which you are talking about. So there is also mumps orchitis. So they may have both simultaneously.
Yes.
Okay. Now all these conditions where they were used, starting from the first one, exposure to radiation, it was done for benign condition in the past. Nobody does it anymore.
So,
now, for acne vulgaris or even for scalp conditions or for nevi, etc., that is not used anymore. So that is gone. But surgeries in that region are important. One in view of the recurrence, and also in view of the malignancy, a benign condition which was operated, which is shown up as a malignancy now.
Yes.
Right?
Yes.
So these are some points that I thought I'll add. And when you're taking history of mumps in the childhood, it's with parotitis in mind.
Parotitis, right.
Not just immunity, that is what. Okay, history is more or less done. Based on your history, what clinical impression you're making?
Based on the history, sir, this seems to be a malignant swelling because there is rapid increase in size in the past 2 months, and also initially it was painless in nature and now it has become painful in last 2 months. So there might be a benign swelling that has changed to malignant swelling.
Yeah, is it possible that the pain and the other features that have appeared could be indicating some inflammation in a swelling? That also is a possibility. Because we have not yet come to the examination where many things would be ruled out. But in history, you can't be so sure. One thing is you can say in history is that I think it's a parotid swelling.
Yes.
I think it's a benign swelling which may have undergone a malignant change. That's how you think.
Yes.
Which may have, may not have, but may have. And then you can say because 2 months sudden change, appearance of pain, rapid progress, etc. Those things that come in.
Yes, sir.
Okay, let's go to the examinations now.
Right, sir. I examined my patient in a well-lit room after taking informed consent in a sitting position. Patient was conscious, oriented, alert, and cooperated. He was of average build and performance status is 90 by Karnofsky. BMI is 23. There is no pallor icterus, cyanosis, clubbing or edema. No generalized lymphadenopathy. BP is 110/70 in right arm supine position and pulse rate is 80 per minute. So here's the picture of the swelling, and then I'll move on to the head and neck examination. On inspection, facial symmetry is not maintained in view of the swelling in the right parotid region. So there is a lobular swelling of approximately 8 into 7 centimeter located in the right parotid region. Right ear lobule is pushed upwards and outwards. Swelling is obliterating the groove between the ramus of mandible and mastoid process. The surface appears to be irregular and skin over the swelling appears reddish blue. There are multiple dilated veins over the swelling and margins of the swelling are well defined. There is no other swelling noted in the neck. On palpation, there is a lobular swelling of 8 into 7 centimeter with irregular surface, which is hard in consistency, slightly tender to touch and restricted mobility over the underlying structure. Overlying skin is not pringible and swelling appears to be adherent to the overlying skin. Curtain sign is positive and temperature above the swelling is slightly raised. There is no cervical lymphadenopathy. Coming on to the examination of the facial nerve, there are no signs suggestive of facial nerve palsy. Patient was able to close the eyes and appearance of furrows on forehead by looking up was present. On asking the patient to down, there were corrugations on the forehead and tone of the buccinator was normal. When patient was asked to blow with closed mouth, he was able to blow a whistle, and on clenching the teeth, masseter was taut, and on grimacing, the platysma stood out. Coming on to the examination of the oral cavity, mouth opening is adequate. Good oral hygiene. There is no medial displacement of right tonsillar pillar. Parotid duct on palpation was normal. There is no purulent discharge from the parotid duct. Movement at the temporomandibular joint was normal. Contralateral parotid gland was not palpable. Cervical spine, ear, nose, throat, and scalp examination was normal. Systemic examination was also within normal limits. That's it.
Now let's take the examination.
Yes, sir.
One by one from the beginning. I mean, general examination is fine.
Yes, sir.
And this picture you should show for some time.
Yes, sir.
Yes. Now, you mentioned that there is a lobular swelling.
Sir.
What do you mean by a lobular swelling?
So it is.
There is nothing like a lobular swelling. The surface is lobular.
Okay, sir.
Which you mentioned later on. Because
Sir.
you see lobules on the surface. I'm not saying it is wrong.
Sir.
The surface appears lobulated.
Sir.
Or the swelling appears lobulated. You can say that. But
Yes.
there is nothing like a lobular swelling. That's what I was trying to say.
Right.
Correct?
Right.
And the skin is definitely stretched.
Yes.
And I don't know, in your first picture, there is an area of the skin which shows, yes, this area. This shows a discoloration and it's about to give way. Is that the area where some needle has gone in or what has happened? Yeah.
Yes, sir. Yes. Sir, actually FNAC was taken, sir.
So you can mention that because that change is very obvious.
Yes, sir.
Right. Because the rest of the skin looks different in color, right?
Yes,
the
sir.
surface appears lobulated. Yeah.
Yes.
And it is a shiny skin.
Yes, sir. Shiny skin and multiple dilated veins were present, sir.
And I can see that although it is a tilted patient, that the angle is getting pulled in the opposite direction. So are you very sure that there was no facial nerve involvement?
Yes, sir. Yes, sir. There was no facial nerve involvement, sir.
Okay. What else was there? You mentioned, yes, the local temperature is raised.
Yes, sir.
That's what I was trying to tell you when you were giving a summary of your history, that it could be an inflammatory change. How do you explain this local temperature rising? That's not a sign of malignancy unless it is a sarcoma.
Sir. So local range of temperature could be due to the inflammatory changes, like mostly it happens in abscess, but because we have taken a FNAC through this, so maybe there is some cystic component that have
It is,
taken.
it is possible. And
Yes,
also right where exactly your cursor is now, that's
yes,
where
sir.
you can see some bit of peau d'orange, as they call it, because
Yes,
skin lymphatics get blocked or there is inflammation, even that can give this picture. You getting my point?
yes, sir.
So it is possible that needle has caused all this. And what did you mention about the borders? Are they well defined?
No, sir. Borders were, sir. Actually, margins were well defined, sir.
Because I can see the anterior border or the anterior border of the swelling. Usually, I don't use the term, I don't use margin for swellings,
Right,
although I have no problem with anybody using it. But I like to use borders,
sir.
use margins for the ulcers, etc. It's easier.
Right, sir.
Now, I can see that there is some problem with the right angle. I don't know, right angle of the mouth. But that's okay. You've done the examination. I can't take it away from you. What exactly do you mean by curtain sign?
Curtain sign states that according to the curtain sign, because the parotid is invested in the deep fascia, the deep fascia is limited by it is attached to the zygomatic arch from above. So the any swelling that is rising from parotid cannot be moved beyond the zygomatic arch. This is curtain sign.
Yes. What is its significance? This attachment has many other important features, like when it is, this is a deep fascia which invests the parotid and gets attached to the zygomatic process. So it's a tight compartment that the
Yes, sir.
parotid is lying in. And
Yes, sir.
if there is a parotid abscess, it's under a lot of tension,
Yes,
right?
and that is why it
Causes
causes pain, sir.
so
In case of
severe a pain that
yes, sir.
it is very, very important to mention that. That I think is by and large uh, done. But I was very keen on knowing whenever you have such a large parotid swelling, Neha,
Sir,
always make it a point to talk about the mandible and
right.
also about I think you did mention, but I would like you to repeat. What is its relationship with masseter?
Sir, it was not freely mobile over the masseter, sir. It was kind of, there was limited mobility over the masseter, sir.
Now, because I can see that it is lying over masseter, and this would produce uh, some bit of mesenteric spasm because the swelling is not looking good. It's not looking like a innocent benign swelling. Okay?
Yes, sir.
Now we will see as we go along, but importantly, look for its relationship to the masseter. How did you test for fixity to the masseter?
So we asked the patient to clench the teeth and masseter becomes taut, and then we mobilize the swelling in the superior, inferior direction and medial and lateral direction.
Like now, how do we make this answer better? Whenever you're describing fixity of any swelling to the underlying muscle, there are 3 steps in the examination.
So,
Step number 1, please examine when the muscle is not taut. So it is lax, and make sure that it is not taut to begin with. Because if there is a mesenteric spasm, the mouth opening would be inadequate. There will be trismus. So in this patient, that was not an issue. So in a relaxed situation, any muscle,
yes,
then you move the swelling at right angles and along the direction of the muscle fibers.
sir.
Part 2, make the muscle taut, but confirm that it is taut. If you don't confirm it, then even if you have made it taut, it may not be rightly taut, because like they do it in the fixity to the pectus major, the patient may not be making it very taut. So that is why it's important. And then third means repeat the step 1, that is move the swelling along the fibers and at right angles to the fibers. So this you must mention exactly as I told you.
Right, sir.
We'll ask the patient to keep the mouth normally, move the swelling along the fibers and at right angles. Then we'll ask the patient to clench the teeth and confirm that the masseter is in a state of spasm. And third, we'll try to move the swelling along the fibers and at right angles to the fibers of masseter.
Yes.
And then you'll know whether it is fixed or not. Okay.
Yes.
Now, where did you palpate for the parotid duct? You mentioned that it is normal.
Yes, sir.
Where did you palpate?
Sir, parotid duct is palpated along the taut masseter, and it is found at the junction of the. It is found at the line joining the tragus and the angle of mandible at the about 2/3 and 1/3 junction.
Angle of mandible is not a correct answer. From the angle of the mouth to the ear lobule, you draw a straight line, divide it into 3 parts, and it's in the junction of the lateral, the lower the 1/3 towards the mouth, that is, and 2/3 towards the tragus. That's what you would do. Okay. So generally, these were my questions. Now, whenever you're examining a head and neck swelling, you mentioned it, but I'm reinforcing it.
Sir.
Examination of cervical nodes is very, very important. You mentioned that there's no cervical lymphadenopathy, am I right?
Yes, sir.
But don't forget to mention that on either side. That's number 1.
Right.
Number 2, always describe the examination of the ear. Although in head and neck, we do describe the examination of ear, nose, and throat. Oral cavity, you described beautifully. But do describe examination of the ear also properly.
Right, sir.
In this case, it will be, it's actually sitting there, and the ear lobule is lifted up. Why
Yes.
does the ear lobule lift up, Neha?
Sir, because the swelling is confined to the zygomatic arch and posteriorly to the mastoid, so there is no further space for the swelling to grow. That's why it pushes up the earlobe.
It is actually, you have to understand, if you watch any of my videos, I've described it many times. That's the way that the external auditory canal is going, and the swelling is lying on either side. Okay, and as the swelling increases in size, the only way it can go is by lifting it up, and it's the taken tube that gets lifted up. I'll show you again on the picture.
Yes.
If I can now, I'll show after I become the discussion, and then that lifts up the ear lobule. Okay, come to the summary and diagnosis.
Right, sir. To summarize, 70 years gentleman with no known comorbidities presented with history of progressive swelling in the front of and below the right ear for past 2 years with pain and rapid increase in size for past 2 months. On examination, lobular swelling of size 8 into 7 centimeters in the right parotid region, irregular surface and well-defined margins, hard in consistency, slightly tender, fixed to the overlying swelling with restricted mobility over the masseter, and with no signs of facial nerve palsy and deep lobe involvement. My provisional diagnosis is 70 years gentleman with right parotid swelling, probably of malignant etiology with no deep lobe or facial nerve involvement, most likely carcinoma of the right parotid gland.
Okay, let's make it better. Go to the summary and link it to your diagnosis. You will understand what I'm trying to say.
Sir.
Can you read that again, please?
Yes, sir. 70 years gentleman with no known comorbidities presented with history of progressive swelling in front of and below the right ear for past 2 years.
You wasted a lot of time. I was thinking I'll take it at the end. There is a swelling in the parotid region. What are the boundaries of parotid region?
So parotid region is defined by the 2 horizontal lines and 2 vertical lines. The upper horizontal line is drawn from the zygomatic arch. The lower horizontal line is drawn from the angle of mandible, and anterior vertical line is drawn through the midpoint of the zygomatic arch, and posterior is drawn from the mastoid process.
What is its significance?
It signifies that in any swelling lying in this region is most likely to be of parotid origin unless proven otherwise.
So why are we constantly repeating this? Presented with the history of progressive swelling
So
front
that,
and
right, I understood.
so there is a 70-year gentleman with no comorbidities with a swelling in the parotid region of 2 years duration with a rapid increase in the last 2 months. Then on examination, there is nothing like a lobular swelling.
Yes.
On examination, there is a parotid swelling. I would be more interested in its consistency, which you said is hard. With irregular surface with well-defined margins, slightly tender, fixed to the overlying skin with this and underlying masseter. That's what restricted mobility means. What here?
Yes, sir. That is, it is fixed to the underlying masseter, sir.
So it will be fixed to the overlying skin and the underlying masseter with no signs of facial palsy or deep lobe involvement. Likely to be, next slide please. Likely to be a malignant change in a benign parotid swelling.
So,
Now, can you give me a diagnosis the correct way now?
sir, 70 years, gentleman with right parotid swelling, with no deep lobe and facial nerve involvement, likely to be carcinoma of the right parotid gland, and
I'll give it to you. Don't worry. You're doing fine. 70-year gentleman with a right-sided parotid swelling, right?
yes, sir.
Probably a malignant change in a benign swelling. Because you had a benign swelling earlier.
Yes, sir. Yes.
That's it. With no facial nerve involvement or no deep lobe involvement.
Right, sir.
The impression is carcinoma of the right parotid gland. I think that you must have understood. I'm just trying to put things in perspective.
Right.
He didn't have a malignant swelling 2 years back.
Sir.
It is undergone malignant change, so it becomes significant. Secondly,
Yes.
it gives you that breathing space to cover yourself. There is a question asked. So you can
Sir.
say there was a benign swelling which is undergone a malignant change. Now
Yes.
you can be asked, why do you think it's a parotid swelling? That's why I was giving you that hint.
Yes.
So it starts with, nobody's going to ask you why is he 70-year-old, which he is.
Sir.
Now, why does he have a parotid swelling? That you have to tell me. It is lying in the parotid region.
Yes.
Why do you say it's a malignant change in a benign swelling? You would say 2 years back it was a benign swelling. It had none of those features. In the last 2 months, it has shown a rapid increase in size, fixity to the masseter, fixity to the skin. Right?
Yes, sir.
I suspect that there is a malignant change. Okay. But
Yes.
what is the flip side? You mentioned it here. I don't see any lymph node involvement and I don't see any facial nerve involvement.
Yes.
Therefore, be very, very, if there was a facial nerve involvement here, you could be stronger with what you're saying.
Yes, sir.
Otherwise, you're just trying to balance it out because you will be doing investigations
Sir.
to eventually come to a diagnosis. But very nicely presented, Neha. Try to use these. I've just made 70% presentation into a 75% presentation. That's all I've done. And that's what you should aim at. But important thing is, don't miss out subtle points. See how mistakes keep getting compounded. You are somewhere, you must have read it. If you read a book, sometimes casually, or if you read your Dr. Google and the internet stuff, they will mention, oh, this is the lobular swelling. They don't care that you're going to appear for an exam. The information is for everybody there.
Yes, sir.
Right. And in our casual conversation across the bed also, some student can say it is a lobular swelling. But I will stop him. I'll tell him, no, it's a swelling with a lobular surface.
Right, sir.
Or it's a lobulated swelling.
Yes.
There is a difference.
Yes, sir.
Please use the words carefully.
Yes.
Looks as close to being perfect as possible, but do not miss out those points.
Yes,
Look,
sir.
the trouble is, you may actually make the best presentation. I'll still have a few points to suggest, which is just to make it better. That doesn't take away from what you presented. Like,
Right.
don't forget to mention parotid region. It will help you. Don't
Sure.
forget to mention those points. How did you look for facial nerve involvement?
Sorry, sir.
How did you look for facial nerve involvement?
Sir, there are few tests we do for facial nerve involvement. Like we ask the patient to close the eyes, and then we ask the patient to blow a whistle, and we ask the patient to look up on the roof, and there should be appearance of furrows on the forehead, and there is while frowning there should be appearance of the corrugations on the forehead, and tone of the buccinator is to be checked when we ask the patient to blow with closed mouth. and we have to check for the angle of deviation of the mouth, and we check for the platysma by asking the patient to stretch the neck.
What all muscles you're testing?
Sir, when we ask the patient to close the eyes, we are looking for the orbicularis oculi. And when we ask the patient to look up and we check for the furrows, then we check for the frontal belly of occipitofrontalis. And while checking for the appearance of corrugations, we check for corrugator supercilii. And when we check for the tone of the buccinator, then when we ask the patient to blow the whistle, then we check for the orbicularis oris, and for when we check for the deviation of angle of mouth, then we check for levator anguli oris, and when we test for the stretching of the neck, we check for platysma.
Okay, that's more or less done. It was just to repeat what we have been teaching regularly. Now, how do you proceed? So we got a. I'll just use my pen. So our diagnosis is 70 years gentleman with a malignant change in a parotid swell. Why do you say it's malignant change?
So points in history are there is a rapid increase in the size over a period of 2 months, and initially the swelling was painless in nature, and it has been now become painful over 2 months. And on examination, the swelling appears to be tense and it is hard in consistency, irregular surface. The skin over the swelling is not pinchable and it is fixed to the masseter. Also, the veins are dilated over the swelling, and skin is shiny in appearance.
Okay, so you should have started by points in history, age.
Age.
Right?
Yes, sir.
Then sudden increase in
Sudden
size. 2 months, right?
Yes.
Painless becoming painful. I'm repeating, it can be just inflammation also.
Yes, sir.
Then fixity.
Fixity.
Or hard consistency.
Hard consistency.
So all this together.
Yes.
And then I mentioned hard consistency and fixity. Everything put together is making you think in terms of this being a malignant swelling.
Yes.
Now, if it is a malignant swelling, your approach will be totally different. Therefore, you need to define it in that sense. I'm just trying to okay, never mind. Now, finally, when you come to the entire history, examination, your clinical impression and diagnosis, you need to build up your mind on how are you going to approach it. So what would you do?
Sir, to know the organ of origin, though it is already known, but to confirm my diagnosis, I'll do a FNAC, which I'll do ultrasound guided to confirm my diagnosis, sir.
Okay, so first is your diagnosis. That is what you're saying?
Yes, sir.
Okay, so you do investigations to confirm the diagnosis.
Yes, sir.
How do you go about confirming the diagnosis?
I'll do a ultrasound guided FNAC, sir.
So first is investigations to confirm, then confirm the diagnosis, support the diagnosis,
and plan the treatment.
And to treat.
Yes.
Investigations to confirm, to support and treat. So that is how we normally divide it. Yes. What do you do to confirm?
To confirm the diagnosis, sir, I'll do a USG guided FNAC, ultrasound guided FNAC.
पूछो इसको. Can you hear me?
Yes, sir.
So to confirm what you do, you said I'll do ultrasound guided FNAC. So you say your answer is I'll do FNAC. Please listen to what I'm saying carefully, because
Yes,
I've seen examiners and the way the various points are understood by them. So it's better to approach it in this manner. FNAC, preferably
ultrasound guide.
ultrasound guided. This is important to use the term preferably. It's not the same like now you can say for thyroid. And 4-5 years back, before the triple test came in, a lot of places the students had to face this, because I taught them, you'll do FNAC preferably ultrasound guided. Now, they were often asked this question, why ultrasound guided? You getting what I'm saying?
Yes,
So
sir.
the term is, please mute yourself. So you'll do FNAC, preferably ultrasound guided.
Yes, sir.
Okay. Why do you want an ultrasound?
Sir, it will confirm the organ of origin. It will also tell me about the ecotexture of the gland, and it can also comment upon the cervical lymph nodes.
That's okay. So that is not going to help you with your FNAC. How would it help you with your FNAC?
Sir, it will guide us to exactly the point from where we need the
So
tissue.
that's a better answer. So it will guide you into taking from the maximum yield, right?
Yes.
And secondly, you will avoid the hypoechoic areas so that you don't get a no-show.
Yes, sir.
Okay. So it will guide you. Number two, it will improve therefore the yield.
Yield.
And in addition, it will tell you about the deep lobe,
Low bands of cervical lymph nodes.
neck nodes, and the surrounding structures, etc.
Yes.
So that's your answer.
Yes.
Okay.
Yes.
So you've done an FNAC, preferably ultrasound guide. There is a lot of controversy over FNAC, and therefore I wanted to talk about it. The controversy is in a benign swelling. I'll request others to please mute yourself. I do it here. Okay. Now please don't disturb in between. She is to be unmuted. Everybody else should remain muted. Now, what was I saying? It gets disturbing. Please don't disturb the flow of thoughts. In a benign swell, what is the minimum biopsy in carotid?
So 5.
Minimum biopsy in carotid. Your answer is?
5. We take 5 chances.
That is a wrong answer. That's not a biopsy. FNAC is a cytology.
Yes, sir.
So what is the minimum biopsy?
So we don't do biopsy. Sir, in parotid, superficial parotidectomy is the minimum biopsy.
What did I ask you? Same question.
Yes,
so
sir.
The answer is superficial
Parotidectomy.
Parotidectomy. And I have a suggestion. What
Yes,
you
sir.
know, don't try to forget it.
Yes, sir.
It's important to understand that what you've learned is correct and stick to that. Don't read something new and jump back.
Yes, sir.
You are answering another question. Why don't we do incisional biopsy or core biopsy?
Sir.
Why?
So generally in parotids, we do not do an incisional.
I am asking the same question. You should just answer the question.
Sir, whenever there is an ulceration over the swelling or...
No, my question, don't change my question. My question is simple. Why we don't do it? Don't say generally we don't do it, generally this is there. No, why don't you do it?
We don't do it so that the anatomy can get distorted by taking the course, and also there is a chance of seeding, and also facial nerve can get damaged.
So that's making a little more sense, right?
Yes,
So
sir.
one is you can produce parotid fistula.
Yes.
It happens. I've seen patients with this. Two, it can cause damage to facial
Facial now.
nerve and parotid duct.
Yes.
Three, seedling or seedings. Rest are all not, people are typing left, right, and center. Don't, that's not a correct answer. This is the complete answer. Okay.
Yes.
So we
Yes.
don't do any core biopsies or incisional biopsies. We do FNACs mostly,
Yes.
ultrasound guided. It becomes equally effective. And a minimum biopsy here is superficial parotidectomy. Neha, what is the minimum biopsy in thyroids?
Sir, hemithyroidectomy.
Very good. So logic is the same. I want you to remember the two together. So it becomes automatically easier. Same reasons. Hemorrhage there in addition. You can have seeding there. You can have damage to the recurrent laryngeal nerve and parathyroids in addition. That is what it is. Clear?
Yes, sir.
Clear? Great. Now, so you have made a decision about FNA. So a lot of people feel FNA is not required if the clinical diagnosis is benign. Why? Because in any case, that is a treatment if you're doing surgery, superficial parotidectomy.
Yes, sir.
So why should you do FNAC? It's a point that is often asked.
Sir.
Okay, and I've faced it in many places.
Sir.
People have asked this. Now, some people who are for it, these are those who are for the cons. What are the points in favor of it? Pros. One, there is a series of tuberculosis of parotid that I have published.
Sir.
They were all detected after surgery. And tuberculosis is very common in this part of the world. So if you have a preoperative diagnosis, you don't need surgery, no?
Yes, sir.
But if you don't do FNAC, you can't make that diagnosis. Number two, you may not be able to pick up certain other conditions like lymphomas, which again is there. I've taught, if you watch my YouTube videos, you'll find this answer. But third is very important, which is applicable to all FNACs. And that is, what is that?
Warthins.
You can pick up warthins, but that doesn't change anything. For tuberculosis and lymphoma, you may do without surgery. So there is an advantage. Warthins would still require surgery, so it changes nothing.
Yes.
But a major disadvantage, which one I said was, you're going to do superficial parotidectomy for this anyway. So why should we bother? But the reason is, we are doing it to exclude tuberculosis, lymphomas, so that we can treat them without surgery. The other problem with FNACs, which is everywhere. What is the major problem with FNACs anywhere in the body? False negative.
False negative.
So you may actually be misled into believing. Now I'm going to put one very important pro factor, which is if you can detect carcinoma. You see, all these arguments were all right till the time we didn't have very good imaging. Now with imaging, so many things can be sorted out. And if you read American books, the first investigation for parotid is contrast and CT scan.
CT scan.
Very clear.
Yes.
So you should be prepared. Where are you answering? Where? So use imaging as a loose term. We'll come to see CT soon. Carcinoma, if detected earlier, can change your plan. Then you won't go for superficial parotidectomy. You will go for total parotidectomy.
Total conservative.
And depending upon whether facial nerve is involved or not,
conservative or
a radical parotidectomy. So you can take that consent, and also neck dissection would happen. So you will prepare yourself mentally, and you can discuss the case in the MDT with the same basis. There is an advantage. So there are advantages and there are disadvantages. Okay.
Yes.
So coming to the other points, which I thought some people would raise later on. So we'll kill them here only. So basically, investigations to confirm the diagnosis will include mainly FNAC, preferably image guided, and then you can talk about imaging. What all imaging? One you mentioned is
CECT, sir.
high resolution ultrasound. Always mention that. Then is contrast enhanced CT scan. And third is MRI.
MRI.
High resolution ultrasound can be done in all. It's very useful, but it's not very good for because of the mandible being closed. The bone is a barrier for this. No, don't do the job that you're looking for. Where do you do CCT? According to the US protocols in certain centers, ultrasound. The first investigation they're going to do is contrast and CTC. So in any case, it is done. What are the indications for CCT in parotid swellings?
So facial nerve involvement.
You started with the last one. That is the problem. Deep lobe.
Deep lobe involvement.
Then
facial nerve.
Malignancy. Malignancy.
Yes, sir.
Third?
Facial nerve and then neck.
No recurrence.
Recurrence.
Suspicion of skull base involvement.
Yes, sir.
Or obviously facial nerve.
Facial nerve.
These are the indications.
Yes.
Deep lobe, malignancy, recurrence, and involvement of the facial nerve. Where there is a doubt, large swellings, no, where you can doubt that skull base may be extending up to the skull base.
Yes, sir.
Now, all those nerves that come out of the base of the skull, they include various cranial nerves that you examine in the oral cavity also, 9th, 10th, 11th, 12th. All these nerves will be there for oral cavity examination becomes important. If the skull base is involved, you need a CT. Indirect or direct involvement of skull base would mandate doing a CT scan. Indications for, and CT is very good for nodes, right? Classical and cervical pattern of nodal involvement so that you can plan neck dissection accordingly. Now, where do you do MRI?
So facial nerve involvement is there when we do MRI.
Intact facial nerve also is an indication in a malignancy because you want to actually see how close it is and also how much you can preserve it. Do you know most of the malignancy, everything in parotid grows along the nerves, and some cancers do go along the nerve more common. Which are those? Adenoid cystic
Carcinoma, sir.
It goes along the facial nerve. So sometimes, the gland may not show initially, but you would like to see the extent.
Yes, sir.
And it allows you for the, if you look at the soft tissues, they're better seen with MRI. So that takes care of it. A lot of it is covered. When do you do what? Okay. Now let's go further. Where do you, once you've done these investigations and you've got your diagnosis right, what is surprising is there's no facial nerve involvement in spite of the size being large. Number two, there is no lymph node involvement in spite of the size being large. So these points go against malignancy in your case, which is important.
Sir.
Against malignancy. In your case, I'm talking only in your case. One, no facial nerve involvement. Number two, no lymph nodes. No lymphadenopathy. Number three, what else? Deep lobe involvement, because the incidence of malignancy is higher with deep lobe involvements, right? Yes. Although there's no direct connection, but it is believed that it is higher. Very much like in thyroid, if there is a retrosternal extension, the chances of malignancy are higher. But then there's no correlation. So that part is done. So we'll have a reason to suspect that it is not all basically malignant. So how do you now treat this patient? What options do you have? Options of management.
So we can offer surgery for the patient.
Surgery. Okay. Is there anything else you can offer anyway? Nothing.
No, sir.
This treatment of choice is surgery, no other
Surgery.
treatment. Now this you will discuss in the MDT, or some people call it MDM now, multidisciplinary meetings. And you must have everything in mind. Patient should be explained. How do you counsel this patient for surgery? When you're saying surgery, what do you mean? What surgery?
So in this case, as the deep lobe is not involved and facial nerve is also not involved, we can go for superficial parotidectomy.
Superficial parotidectomy. That's the wrong answer. Why? I've told you FNAC is carcinoma. There is no superficial parotidectomy done for any carcinoma. So
Sir,
don't just shift. Don't get confused. Your case is a patient with parotid carcinoma. Which is the most common carcinoma of the parotid?
Some carcinoma is
Mucoepidermoid, right?
Yes. Yes.
So, whichever the carcinoma, your answer is not
Total
superficial parotidectomy.
Total
Please.
conservative parotidectomy.
Now comes the question of which of the two you will try to do total conservative. Okay.
Yes.
Now, how do you counsel this patient?
So we will counsel the patient regarding the facial nerve damage during the surgery.
I'm waiting. Finish.
And also, sir, in the post-op period, he can have Frey's syndrome, that is gustatory sweating, along the region of the surgical excision of the parotid gland. Patient
So, Neha, when you're answering,
yes,
counseling should involve first what surgery you're offering. You'll have to tell the patient, I'm going to remove both your parotid lobes, superficial and deep. And you will tell him that superficial and deep is not an anatomical differentiation. So I cannot promise you that I'll remove one part and the other part would remain. And you should also tell your patient that surgery of parotid is nothing but surgery of facial nerve. So I'm going to go along the facial nerve. The facio-venous plane of Patty would separate the superficial from a deep lobe. So since it lies so close to it, I can't promise you the facial nerve may not be involved. So don't say damage first. You may find that finer and tiny branches of facial nerve are involved. Okay? Yes. So you are saying total conservative parotidectomy. And then you will explain what it means. And you'll say facial nerve is very close. And if the facial nerve is very close, how do I preserve it? I'll try and make an effort to preserve it. And if I can, I'm happy, you're lucky. If I can't, I may have to sacrifice with or without reconstruction, which may not be the best option. The other complications you can discuss certainly, but these are the important ones.
Yes.
And for reconstruction, I will use another nerve.
Greater auricular.
That again becomes your responsibility. I may use greater auricular, I may use sural nerve. So you'll have to tell the patient and take a consent. You can't just do that. Clear?
Yes, sir.
So that is your one consent. What is the other consent? What? Okay. Then how much? That we have covered. Then third, the consequences. And fourth, how much also includes the nodes. I may have to go for neck dissection also. Because if you find on the table, some people like to do an ultrasound, and you find there are nodes, they will still go for neck dissection. How do you define radical parotidectomy?
Sir, in radical parotidectomy, we remove both of the lobes with facial nerve, and also the radical neck dissection is performed.
So, for the benefit of all students, the correct answer is en bloc. Listen to the word. Removal of both lobes of parotid with facial nerve with some sort of selective neck dissection, not radical neck dissection. Most people would agree that if you remove facial nerve also, that is radical, right? This is radical. Now, if you preserve the facial nerve, it becomes conservative.
Conservative.
Whenever you say parotid,
No.
mute yourself, please. Mute. Mute, please.
क्या हुआ भैया? अरे वो जा
We need
उसमें जा
someone.
रहा हूँ,
Mute
टिकट करने जा रहा
yourself.
हूँ। परेशान नहीं हूँ मैं एटलीस्ट इसका वो मार्क्स नहीं पे
They disturb me. That's not good, no. Mute yourself. Be disciplined that way. Now, whenever you're removing the parotid, or when you're saying parotid gland removal, it is one lobe I've drawn above, then one lobe we have removed from below. The facial nerve goes in between. Maybe I can use a different color for that. That's the facial nerve. And remember, we have retromandibular vein here. And we also have the parotid duct removed. So this amounts to that. So gland is both lobes plus duct. Please understand. Clear?
Yes, sir.
So both the lobes and the duct. But we preserve the facial nerve. If the facial nerve is not, if all the branches are not, I asked that question in your WhatsApp group, Pes and Serenus, which we'll discuss as we go along. Now, so that's what you're going to tell the patient. That's what you're going to offer the patient, right? So don't be incomplete. Say en bloc removal. En bloc word is very, very, very important. Now, let's go to the discussion about when you've done the parotid surgery. I think you have mostly answered everything beautifully. Therefore, I would like to ask you only. So it's en bloc.
Yes.
And I'll once again request others to mute themselves. Why are they disturbing? I'm giving you half a minute to mute. You're wasting everybody's time. Now, so en bloc is important. En bloc is, Neha, are you able to hear me?
Yes, sir. Yes, sir.
So en bloc includes both lobes of parotid plus duct, done, plus facial nerve in case of radical, plus ipsilateral neck, selective neck dissection. And as simple as that. And suppose there is a branch of, you have the Facial nerve coming out of the stylomastoid foramen from under the mastoid process. And this is where it is a major trunk which divides into two.
Two, motor and sensory.
Not motor and sensory.
No, sir.
That's the undergraduate problem. Two trunks.
Two trunk.
Temporo or cervicozygomatic and cervicofacial, which divide into further two, and one continues down from here as, or sometimes from here as, ramus mandibularis. And you people end up calling them 5 branches. There are more than 5, they further divide. And these are the most important branches during carotid surgery. Because if you don't preserve these, and you preserve this, there's no point, because the supply is gone. This is pes and serenus, and there is connection between them, which can help in the recovery of, typically like the goose foot. Now it looks like the goose foot as I've drawn. Now these dots are the connections that you have in between. So they allow for the branches to take care of each other also partly. But sometimes it's a small branch which has got damaged. You can repair it using the greater auricular. But there are disadvantages of greater auricular. The disadvantages being it can be a malignancy, so it may be.
हाँ भाई.
Again, somebody is unmute. I don't know how do they manage.
नहीं सिर्फ प्रेग्नेंट गए थे और कुछ नहीं.
Mute yourself. Who is
हाँ
this?
बताओ. 0.89 ऐसा कुछ है ना.
No, let me find out who is this.
जरूरत नहीं है छोड़. हाँ.
Vinit Semal, can you hear me? Okay, wasting time. Now, so this is what is pes and serenus that you all answered very well. So you'll take all this discussion now. How do you go for surgery? We can cover this too. Tell us about, this is about your presentation. I think you've done fantastically well. I think not, you cannot all clap, but you can show your hand. I think that's possible. By show of hand, applaud for Neha's presentation. I am visible, so I will clap. Excellent presentation. They're all showing their hands now. Beautiful. Right, Neha, you can stay put. Please tell us about the management now. Surgery. We have taken the consent. The treatment is surgery. What surgery? Please start.
The total conservative parotid.
Yeah, let's talk about the position. Or maybe I can take it from here. Or you want to talk about it? How do you position?
Yes, sir. We'll position the patient in slightly tilt up position like 35 degrees and head rotated to the opposite side. And while draping, sir, the angle of the eye and mouth should be visible.
That's correct. So angle of eye, mouth is visible. But the important thing is the table is 15 degree up.
15 degree up.
At the head end. So it's reverse tendon and bug position. And we put a pillow, which is called the Dunhill pillow.
Between the shoulder blades.
Yes. So you can just put this pillow. This is available.
Yes.
It fills the neck. It is inflatable. Or you put a sandbag. Okay. Now the head is tilted to the other side. Now come to the incision. You mentioned very nicely about the draping, which I hope everybody would have understood, or they can write their question, we'll take it. So you expose these angles, this. So the draping is, and we take the ear also up in a suture. That's what we do. Usually in ladies, it serves well if they have this little opening there. So I'm just trying to make you understand that angle is important. Okay, now what is the incision called?
So lazy S and or modified Blair incision, which is pre-auricular, mastoid, and cervical incision.
Good answer. Now, so we will prepare the incision with three parts, which you very correctly mentioned. If this is the tragus, this is the incision here, and that's the mastoid process. Go back and you take a little curve and you try to keep this arm 2 centimeters below the mandible. Why do we do that? Why should this be 2 centimeters below the mandible? You're answering or I have to answer?
Sir, in case we need neck dissection, then we can.
No. So I save time. Whereas this is done to save the ramus mandibularis nerve, which is marginal mandibular nerve, which I just described to you. So the incision goes like this. And this is the mandible that you're referring to. The nerve is expected to go here. Right? That's the angle of the mouth. So you can preserve it by keeping. This is done in neck dissections also. I think I'll take neck dissections next time, here step by step or whatever, so that you understand what actually is involved in neck dissection. So let me choose the color. Okay. So that is the incision. It is called modified
Blair's incision.
Blair's incision. There are other incisions also. There is a Wilford Fees incision. Which is only different in that this incision, the vertical limb in front of the tragus, goes inside. So it's from inside the ear. So there is no scar visible outside. This one is as it is hidden. Clear?
Yes.
That is Fees incision. And I'm sure somebody is going to ask me to repeat it. So I'm repeating it before. Now, this is the ear, somebody's ear. And this is what incision you normally give. Now what I'm doing is, don't ask me to repeat it. I will go inside and lift up this flap and come from a little bit only. So there is no incision visible on the face. If it is the same person, please just throw him out. We have the problem, I think. We need Samal. Constantly becoming a problem. Leave it. It's unnecessarily disturbing everybody. I know what's his problem. Meanwhile, you can type your questions. Okay, he goes to the waiting room now. So we have got the incision. Now, how do you look for facial nerve?
So, we have, sir, pointers for the facial nerve. First is the posterior belly of digastric. Then we have Conley's pointer, which is the lower portion of the cartilaginous, inferior portion of the cartilaginous canal. Then the stelloid process, mastoid process, and squamotympanic fissure.
Yes, theoretically, you would score all the marks there. Importantly, this is the mastoid process, and that's where the nerve comes out. Please understand this logic. Okay, so now everything is based on your understanding of this distribution. Now, there are muscles attached here, digastric, posterior belly. Sternomastoid is here. And you'll find the tragal pointer somewhere here. So 1.5 centimeter below it, you find it. Tragal pointer is formed by the junction of cartilaginous and the bony part of the external auditory canal. So from there, the pointer comes down deep to that 1 centimeter below. This is called tragal pointer. You should know it. Now the facial nerve is here. So you can understand what are the ways to approach it. I've always relied on digastric, and I can tell you that it's, for me, the most reliable method, but it depends on how people, you keep dissecting, we dissect the sternomastoid, and deep to that is digastric, and deep to that and at 30 degrees where we find the facial nerve. So it is easier for us. This is my usual approach. And the other approach is very interesting. That is, if I put my finger on the mastoid process, that is index finger, and I point it towards the external canthus of the concerned eye.
Yes.
Deep to that is the facial. Midpoint of that finger and deep to that is the facial. Midpoint of that finger. So that's about finding the facial nerve, and then you go in the, what is the significance of retromandibular vein here?
Sir, facial nerve lies superficial to retromandibular vein.
Good. One is this.
Sir, we have external carotid artery lying deep to retromandibular vein.
That is also correct. That's retromandibular vein. And in all the tributaries from the facial-venous plane of Patty, they drain here. So if you ligate the retromandibular vein or damage it, then you'll make this congested. So when you're dissecting in the facial-venous plane of Patty, you may actually there'll be difficulty because they'll all get congested if you ligate. Right? The nerve lies superficial to that is okay. And we can make it a point to keep preserve it, and with each tributary is the nerve branch going. Let's take it this way, and we dissect in the facial-venous plane of Patty. That's why it's called the facial-venous plane of Patty. And when you got the gland dissected, there is a video of mine on parotid surgery on YouTube. Please watch that for steps, or maybe I'll take separately the surgery of parotid. So if there's some pertinent question relating to that I will take. When you're removing this, when you mobilize the superficial lobe, then what we do is we lift up the facial branches on glove slings so that we cause minimum neuropraxia. We use a glove sling and dissect around it. And as you keep going towards the border of masseter, that's where you will find the duct is coming. And that's the only structure which is. Now, I'll just, if you are okay with it, you can answer by writing in the chat box. You want to see the video? Just now, I'll quickly show it. If you type in the chat box.
Yes.
You want it, but let me see others. Otherwise, we'll take it some other time. I think we'll take it next time, otherwise, so that we can concentrate on this case completely. We'll see at the end, they're all typing yes now. So, let's move. So you've done the surgery, and what kind of, how do you prevent various complications? Suppose you've removed a big gland like you have in this case.
Yes, sir.
No, I can see that all of you are typing. Yes, I'll share with you once I'm finished with the case. So give me some moment. So when you removed a big gland, you're left with a hollow
Hollow.
in the retromandibular space.
Yes, sir.
And also there is a higher risk of Frey's syndrome.
Yes, sir.
Now you can, meanwhile, I answered that in my YouTube group, but you can tell us quickly about Frey's syndrome. What did you understand?
It happens after the surgery for parotid, and it is also known as the gustatory sweating. In this, the sweating and erythema occurs over the region where the parotid, so where the surgical excision has been done uh, which causes excessive salivation by the smell or taste of food, sir.
How does it happen actually?
Because of the damage to the autonomic nervous system and inappropriate regeneration of the parasympathetic nerves.
Yeah, that is actually partly correct. It is also called as auriculotemporal
Nerve
syndrome, because when the parotid is removed or any surgery is done in this region, those tiny branches can be left, and when it comes in contact with the dermis, the innervation goes into the sympathetic pattern, they join together. What that does is creates a gustatory sweating. I think I have covered that in my earlier answer. So how do you prevent it during surgery? One is by taking a thick flap. When you're raising, after making an incision, when you're raising the flaps,
Yes, sir.
you make them thick so that the the nerves are covered.
Yes, sir.
I mean, they don't come in contact directly.
With
It's
the
the skin
skin.
coming in contact with facial nerve. That's where the problem is.
Yes, sir.
And especially if the flap is very thin. Some people also do what? If it's only a deep lobe.
Flap can be taken.
No. Listen, now let me answer that. You can for a while mute.
Yes, sir.
This is to, sometimes some people even put the superficial lobe back. That is not in cancer, in benign conditions. Suppose only the deep lobe is involved, they will just remove they'll remove the deep lobe by lifting up the entire thing, and they'll put it back so that there's no Frey's syndrome. Third is by putting something in between the facial nerve and the skin. So one of them is a temporal fasciocutaneous flap, which is based on superficial temporal artery, or sternomastoid flap, as you were saying, right? Now the sternomastoid flap is based on which artery here? If you're answering, you can answer now, unmute yourself, sorry. You can use a sternocleidomastoid flap, as you said. It is there again in my video. That's the mastoid process. That is sternomastoid. We have occipital artery supplying it in the upper part. Okay?
Yes.
So this is occipital artery branches. So we don't damage them. We just mobilize the attachment from here and shift it medially and suture it to the masseter. So that fills up the space also. So that defect or the hollow, which is cosmetically very obvious, that is taken care of, and the Frey's syndrome also doesn't happen, and the seroma formation or the seroma rates also are lower. Most of you are taught to remember mnemonics. They're useful here. What are the complications? They're all related to F, facial nerve injury, fluid, which is seroma, Frey's syndrome, fistula. So, fluid, facial nerve injury, flap failure, Frey's syndrome. There's one more F, functional. which is also cosmetic. So I think we can skip that. Remember this, that's more than enough. Okay. Now, that is the case. Beautifully presented. We will discuss, if I can see if I can share the video, then I can describe it quickly. Otherwise, you can write your questions and I'll take your questions. All your questions, please type them in the box. Quite a few. Making it big now. Yes. Now, the questions, please. Okay, I'll just share with you the video if I can. I think it will get a little cumbersome. We'll have the video next time. You can ask me questions. That is much better. They'll cover that. So in the chat, please type your questions. So I start from the top. Pragya, good afternoon. Well, low dose radiation, tinea capitis, acne vulgaris, thymus enlargement, adenoid tonsil enlargement. I think that I've covered. Nimesh Tiwari, superficial parotidectomy. That was, I think, in reply to the question. Nerve injury, fistula, hemorrhage, done. TB or lymphomas, then we can do it. Locally advanced deep lobe recurrence, we can do FNAC. We can do CT. That has been covered. MRI for perineural involvement, that is correct. Now involvement resectability, not respectability, MRI, resectability. Superficial, as it is a locally advanced total removal with the nerve preserving the MRND, only if this is Chirag M. As it is locally advanced total removal, no, nerve is preserved. Remember the basic principle, functioning facial nerve is never sacrificed. Functioning facial nerve, functioning recurrent laryngeal nerve, they are always preserved. We'll check if there are any questions on the YouTube people. There are some people logged in from YouTube. So always preserve. So therefore, it's a surgery of the facial nerve. Surgery type lobes, nerve weakness. Okay, Chirag, with removal of the duct. So do we remove duct in superficial parotidectomy? It's not mandatory in superficial parotidectomy. Bhagyashri, haven't seen many cases of parotid in my PG, but yet I am able to follow it. So you explain it. So okay, fine. That's okay. Don't worry about it. You will be fine with it. Bhagyashri. Hayes-Martin maneuver 2 centimeter below it. That's not Hayes-Martin maneuver. Hayes-Martin maneuver is done for, this is Chirag. Hayes-Martin maneuver is done for during neck dissection, not in parotid surgery. In parotid surgery, we preserve it by keeping the incision, the cervical part of the incision a little below. Manya, correct? Manya Diwal. We do that for preserving the marginal mandibular nerve. Can you spell the second incision you mentioned, sir? The name is fee. You pay your fee, don't you? It is Wilford fee. So Wilford, you can remember, well, fee is incision if you mention. That was Uma Devi. I hope you got your answer. And like every time, those who have got their answer will type back that they've got their answer. Original Blair's incision did not involve extension into the cervical region. This is the modification. This is the original one, according to what I know. It can vary. You may find some other answers. It's not relevant. We all use modified now. Yes, there is an advantage of extension into the neck, mind you. The other advantage, which even Neha was trying to answer, can do neck dissection by extending. At least I do it that way. What do? I'll take this incision further down and I'll be able to do supraomoid neck dissection through this. I've done it. There are videos of mine which I'll share. I'll ask Sukriti to share it with all of you. Those videos are there. They're coming out in my atlas. Those who got their answer. Superficial Nimesh Tiwari. Good to see you answering, Nimesh. Temporalis muscle flap is sternocleidomastoid muscle. See, the temporalis muscle flap, the only problem is, we don't use it, is that you have to make another incision above and then tunnel it. You can produce, some morbidity by adding. While using the sternocleidomastoid flap, it is easy to shift it from here only. We are in the same incision. So that's an advantage. But the problem is, nobody can say for sure that Fraze syndrome would be prevented. Now, what is they call it starch iodine test for Fraze syndrome. What they do here is, the area where you get this feeling of sweating and the hyperesthesia, that area we will clean up with betadine, usually the incision area. Okay, and then we'll wipe it up completely clean because it can never disappear from there. You wipe it and put some starch powder on it, which is usually white, that. Then do some salivary stimulation. How do you do that? Vitamin C chewing, lemon, or anything, or for some chocolate. So when you do that, they will be sweating. And that would be causing a change of the starch changing into, because it has to mix up with both, the sweating has to mix up with it. It's all dried up. So it will become dark brown, or some people say it may even become blue. And that's called the starch iodine test for making a diagnosis of Fraze syndrome. So when you're treating Fraze syndrome, how do you know that you've treated it? By the same test. So that is why you can remember starch iodine test. It's for those who are wanting to score a distinction. I suddenly remembered if I cannot. Somebody is keen on asking. Is radiation relevant in India? It is relevant in some areas, dear. Like there is a place called, I got some papers from there. When as editor-in-chief of my journal, I get papers from all over. A place close to nuclear reactor in Aurora. And also, there is a very high incidence of certain cancers that have happened, lymphomas, leukemias, and very common in, close to Chernobyl. There was a higher incidence of lymphomas, papillary cancers of thyroid, and leukemias. They've all been linked to this. So it is relevant. And don't talk about just India and one remote corner where you live. You must be global in your thinking, because India is a global power now, and India is all global. Now, that's the Fraze syndrome question. Any other questions from YouTube? I'll just check it and we'll address. Malignancy, should we do, sir, in case of suspected malignancy, should we go with MRI or CT? I've already answered that. I think you joined in late. The indications for CT scan were basically involvement of deep lobe, facial nerve, skull base. So it is done in recurrent cancers also. These are the indications for CT. MRI is more useful when you're trying to study the plane of your resection and looking for the facial nerve. So CT is done more or less as a, one of the basic investigations by most people. Facial nerve, to study the plane of involvement and the plane of the involvement of the, the tumor, you need MRI. Then we have a lot of people on YouTube actually. Local management of parotid fistula. Ideal management, sorry, I read it wrong. Ideal management is nothing ideal, no ideal. Best thing is to prevent it. But we have treated these with a lot of pain actually. Parotid fistula. Every question is a long answer. One is ideally prevent. When you can't, there are various methods. So naturally, conservative surgery. If the distal passage is patent, that's a rule of law, a rule of surgery or nature or body. Distal passage, if it is clear, abnormal passages stop or they get blocked. So encourage that if you have ligated the parotid duct, which you have, and you just got some gland left, parotid fistula won't happen usually in patients where you've done total parotidectomy because you've left nothing to leak. So this is usually a complication of superficial parotidectomy where the duct has been, either ligated or traumatized, which has undergone stenosis, or there could be a stone. So basic thing to understand is that if the distal passage is blocked by whatever method or damaged, this is going to leak outside if there is a trauma. So clear this or remove this. These are the two options. So you can also go in for a redo surgery. But before that, reassurance, trying to keep the local hygiene fine. And some people have gone to the resection of fistula, that is fistulectomy, along with the removal of the superficial lobe, which is left behind lobe, that is, it takes care of it. But there are people, especially if you're dealing with a recurrent, pleomorphic adenoma, which is the most common benign tumor. If it is recurrent, pleomorphic adenoma, then some people have also given radiation because that dries up the gland. But that's like killing a mosquito with an AK-47. It will dry up the other glands also. So these are the options. There is a role of octreotides also. So there are expectant managements and surgical management. Surgical management, expectant is reassurance, making sure that there is an adequate massage given, and if there is no distal obstruction, it will drain. But naturally, there is a distal blockade, which may take a little while to clear off. If it doesn't clear off, then we have no choice but to go in. And, this is the time when you can try octreotide, which dries up the fistula, like in pancreatic fistula, it can work. And rarely radiation, low dose. But pleomorphic adenoma, which is recurrent, is the only benign condition where radiation is used. You must remember that. The question that I asked you in the beginning, I'm now answering. And then surgery means it is removal of the fistula along with the remaining parotid gland. You can complete parotid surgery, which is easier said than done because it is a all fibrotic area. And this is one indication where you should use a nerve stimulator. Now, one question remains. I thought I'll cover it up in the surgery. When do you use nerve stimulators in parotid surgery? You use it in a recurrent tumor or distorted anatomy, where again MRI can be very useful. Otherwise, not a great use. And what do? Tell the anesthetist when you're doing it. You tell the anesthetist not to
Not to give muscle relaxant.
Yes, not to give the muscle relaxant, otherwise it won't function. That's well answered, Neha. And I'll check for some more question. What is superficial parotidectomy? This is Shivani Anand. Superficial parotidectomy, I'll repeat, is removal of the lobe superficial to the fasciovenous plane of patella. Now I made it very simple. So the parotid gland is divided into two lobes, superficial and deep. By what? The fasciovenous plane, which is here. So removing everything that is lying superficial to this plane is called superficial parotidectomy. If you got the answer, please do write in the chat box that you got your answer, because I like to see people getting their answers. Why isn't parotid duct ligated during superficial parotidectomy? Now, if you ligate it, then the deep lobe, which is not going to be completely atrophic, can create those problems. It will swell up and cause the the symptoms of blockade. So it is better that we don't ligate it. Now we are just about to close. If there are any questions here. Now this is a good question. Who was asked? There's a question in the YouTube which I will take more importantly. That's a more useful question. Sundar Nathan. Disadvantages of greater auricular nerve. Okay, now I'll take this. During surgery for parotid, when we are dissecting, there is this is the fascial nerve, but before this you find the greater auricular nerve, and a lot of us have in the past, not bothered about it. I'll mark it with red, and it gets sacrificed. Remember the fascial nerve. For fascial nerve, I often teach this, and I want you to remember. It is deeper than you think, more medial than you think. So don't start looking for it as soon as you open up. People keep doing it. They keep scratching away to glory. It's much deeper. So therefore, what I do is I use the posterior wing of the incision first. I'll keep going deep, and I hit the sternomastoid, go deeper, find the deep to it. Retraction, I find the posterior area of digastric, and that's when I start getting serious about it. Before that, it's the greater auricular nerve must be preserved. Greater auricular nerve is a very classical advantage that it's available there only, and you can use it. But there's a disadvantage. If it's a malignancy, it's very difficult to be sure that it's not involved itself. It's lying in the same region. And it's not a very sturdy nerve when it comes to post-surgery radiation. So sural nerve does a better job in that case. That's a disadvantage. If there are no more questions, I think we can close it here. Maybe I'll look at YouTube group again. There are lots of questions. Cable graft. What is cable graft? Is a question by Dr. Rajiv Sahai. Now, cable is a cable, and it's a term used for grafting of nerve anywhere. I'll wipe it and put it. Now, to make it simple, I'll just take all the reconstructions in this. That's one end of the nerve, and that's the other end of the nerve. I've deliberately kept them in a different plane. This is to teach what I understand by it. This is the edge, this is the edge. The first thing is you must make sure that you align them And usually we align using the vasa nervosa. And mind you, the surgery is done using an operating microscope, but at least a corneal loop. Now I made it blue again so that I can make the vasa nervosa red. You align them. So that will make it some sort of an alignment. Then we must dissect all around to make it free. There should be no anastomosis done under tension. And then we do. So if you can mobilize and if the ends can come together, we do the same. In your basic skill course, I've taught that repair now, repairing of the nerve. It's not classically the K-stitch, but similar to that. So you go in completely, come back here, go out, come back here, go out and tap. And then you come back and go all around. That's one. And you use at least 7/0 Proli. So naturally it's a micro work. Since you're asking me, I'm answering. It's not what you should know as a postgraduate. Now, if after doing everything, you find you can't bring the two ends close to each other, you have an option to put a cable in between, which you can pick up from anywhere. Say I decided to take the greater auricular nerve and I'll do the anastomosis on either side. That's like the patchwork between. Any other question? If there is none, then we will close this session. There will be many questions remaining. There's no end to what we can do to cover it. It's a huge topic. Neha, first of all, do you have any question as of now?
No, sir. No, sir.
So well presented. Thank you very much.
Thank you, sir.
And can I close the session? You can type in the chat box. Dimesh, thank you. Thanks a lot, sir. In every session there's a new. Thank you. God bless you, Dimesh. And so with that we can close it. I hope you enjoyed it as much as I enjoyed getting it to you all. We try to make an effort to put things together. I think this time, well, Hetu, I hope everything is clear. Others too. So Sukriti tried putting the live YouTube along with it, which seemed to have worked, I think. And we could cover up, but importantly, Neha, you made a good presentation.
Thank you, sir.
Improve upon those points, add that. Saying Manya Agarwal, DNB practical exams are happening soon. This is very helpful, sir. Exams come and go, learn it. That's more important because these are after our courses. I'm going to run an examination OSCE based maybe very soon. You don't fail in any exam, whether it's MS, DNB or MRCS. I'm very blunt about it. Learn the subject rather than bothering about which exam you have to crack, and crack all the exams. Right? Thank you very much. With that, we'll close it. And all the very best to you. Stay safe, study hard, and make a difference. God bless you.